Good morning. My name is Sarah Doughty, and I'm an Admiral nurse at the University Hospitals of Morecambe Bay. Today, I would like to share my presentation on person-centred care. First, I'd like to share the aims and the objectives of the presentation. The purpose today is to demonstrate an example of person-centred care, and in order to do this, I plan to share and discuss a case study involving a patient who has received support from the Admiral Nurse Service at Morecambe Bay for over 12 months. To protect confidentiality, all names have been changed and consent has been gained from the trust, the hospital consultant and the next of kin. The case study will be discussed throughout and will not only demonstrate person-centred care, but will highlight reasonable adjustments which were made whilst the patient was receiving treatment within our hospital. Prior to discussing the case study in depth, I will explain a little bit about our trust, the role of the Admiral nurse, and what our service provides within the acute setting. I'll also discuss delirium and the importance of identifying unmet care needs. By the end of the presentation, I'm hoping I will have demonstrated the importance of person-centred care and what benefits it has had on a patient and their family. At the end, there will be an opportunity for questions, and these will be answered by Diane Smith, Consultant Admiral Nurse at Morecambe Bay. First, I'd like to introduce you to Charles. Charles is a 75-year-old man, and he had been diagnosed with Alzheimer's disease 2 years prior to admission to hospital. He lived with his wife Mary independently, but receiving help and support from their 3 children. Charles liked to follow a routine, and every morning he enjoyed a walk to the local shop to buy his newspaper. Unfortunately, in January last year, the weather was cold and the pavements were icy. Charles slipped and fell on his way to the shop and sustained a lower limb fracture. He was admitted to hospital and the fracture required surgery. The surgery initially went well, but in the post-op instructions, Charles was required to walk partial weight bearing. Furthermore, he was expected to wear a boot to provide support whilst mobilising. Both these requests were difficult to manage. Charles struggled to walk partial weight bearing and he didn't like the boot. He found it very uncomfortable and often walked without it, therefore putting all his weight through his leg. Also, Charles developed delirium post-operatively, and it was at this point that a referral to the Admiral Nurse Service was made. Charles was unsettled, frightened, agitated and frustrated. He just wanted to go home. The ward environment was busy and noisy, and Charles developed behaviours which were difficult to manage at times. Support was needed for Charles himself, his family and the ward staff. Now I'd just like to talk a little bit about our trust and explain the role of the Admiral nurse. Our trust is based across Morecambe Bay area. It's a large area covering 1,000 square miles, which spans North Lancashire and South Cumbria. It operates from 3 main hospital sites, the Royal Lancaster Infirmary, Furness General in Barrow, and Westmoreland General in Kendal, as well as a number of community healthcare premises. Our Admiral Nurse Service was launched in January 23 and now has teams based at Lancaster and at Barrow. The team consists of 1 consultant Admiral nurse, 3 Admiral nurses and 1 admin assistant. Since our service launched, we have created a support group for Admiral nurses from all over the North West. We've been meeting every couple of months to discuss best practice and provide support for each other. The group includes nurses from Morecambe Bay, the Eden Valley in North Cumbria, the Royal British Legion in Lancashire, Trinity Hospice in Blackpool and St Mary's Hospice in Ulverston. Next, I'd like to just discuss a little more depth about the role of the Admiral nurse at Morecambe Bay. We have a referral system in place and we encourage staff to email the referrals to the team. We support and visit any patient with a diagnosis of dementia or who are under investigations from either their GP or memory services. We triage the referral, and if a need is identified, the patient will be added to the caseload. We then attend the ward to assess the patient, and start an in-depth assessment with an assessment tool that we have created as a team. The assessment includes talking to the family and obtaining collateral history. We inquire what brought the patient into hospital. How do they usually manage at home? Did they receive any care? We ask about daily routines. What assistance do they need with activities of daily living? How is the diet? What's their usual sleep pattern? Is there any evidence of sundowning? We also discuss dementia symptoms and how these are managed. And also we ask the family, how are they coping? We encourage family involvement. We offer open visiting and promote the use of the forget-me-not passport. We can offer practical advice and coping mechanisms. And sometimes we just listen to the family's worries and concerns. We provide each family with a bespoke carers pack. This pack contains a passport of care, information regarding John's campaign, relevant leaflets from Dementia UK, including the Admiral nurse helpline number and our contact details. When the assessment is completed, we provide a plan and recommendations for the staff. This can include offering a range of advice on various matters, ranging from nutrition and pain assessment to managing delirium using distraction and redirection techniques. We also work with other teams within the hospital, in particular the discharge coordinators and the complex case management team. We offer support for the patient and their relatives during the discharge planning process. We also support staff and offer in-house training, both ward and classroom based. Another part of our role is supporting enrichment therapies within the ward environment. We organise regular sessions which are beneficial to both patients and staff. Enrichment therapies have been known to provide a purpose to someone's day and can help improve someone's mood and minimise behaviours such as agitation. We work closely with the Pets as Therapy charity. Jill and her golden retriever Barley regularly visit us and they come to the ward to meet the patients. The patients get a chance to chat to Jill and stroke a friendly dog. The patients love seeing Barley, as do the staff. The staff often get as much out of the visit as the patients. Seeing Barley can remind patients of their own pets at home or pets that they had when they were younger. Another enrichment therapy we are involved with is working with the Music in Hospitals charity. This charity has over 350 musicians who visit care environments within the UK. Andy visits us on a regular basis and sings and plays the guitar. The sessions are very well received. He plays a variety of songs from country to 50s pop. Often, even if a person with dementia has lost the ability to verbally communicate, the music can help them connect with others and it can trigger positive feelings and reduce distress. The music creates a relaxing atmosphere on the ward, and often patients who've been low in mood respond well and often end up singing along. Another key part of our role is to promote the use of the forget-me-not passport of care. The document is given to the family and they're asked to complete it and return it to the hospital so staff can use the information to support their relative. Families are encouraged to add as much information as they can so the care can be as individualised as possible. The required information can range from a person's diet, including likes and dislikes, a choice of drinks, day and nighttime routine, bathing preferences, and calming techniques. A key component is obtaining some life history. We want to find out what was important to their relative. Did they have any hobbies? What did they do for a job? Who are the important family members? And are there any special memories? Reminiscence and obtaining life history are tools to enhance the care of a person living with dementia. It helps us understand the person and helps us see them as an individual. Furthermore, reminiscence therapy can help manage behaviours such as by using distraction, which can be effective in reducing distress behaviours. When I first met Charles and his family, I did provide a carers pack, and the family were very proactive and keen to help in any way. They happily provided as much information as possible and completed the passport fully. Charles trained as a shoemaker when he left school and worked in this industry for the whole of his career. Eventually, he became the managing director of a large shoe shop. He was a very organised man and his shop was very successful and employed a large number of staff. Charles was married to Mary and they had 3 children, all of who still live locally. They were a very close family, often enjoyed many holidays together over the years, both within the UK and abroad, in particular Italy and France. Charles enjoyed rugby, fishing and swimming and loved classic cars. Charles also enjoyed quizzes and crosswords and spent time at home organising his papers and documents at his desk. This often helped him relax. He also loved watching films, particularly Christmas films and the sound of music. Mary brought a laptop into the hospital so he could watch films while he was an inpatient. This activity helped with distraction at periods of agitation and also relieved periods of boredom due to the prolonged hospitalisation. As discussed earlier, Charles experienced delirium post-operatively. As we all know, delirium is an acute state of confusion. It's usually put into 3 categories. Hypoactive delirium, where the patient is quiet, withdrawn, drowsy. Hyperactive delirium, where the symptoms include hallucinations, agitation, disorientation and restlessness. And mixed delirium, when a patient can have a combination of both. Charles experienced hyperactive delirium, which lasted several weeks. He required one-to-one support for a considerable length of time. Occasionally, it isn't clear why delirium occurs, but usually there are many potential causes. In Charles's case, he'd had surgery and he was in an unfamiliar environment. Following surgery, he was immobile, probably dehydrated, and also he was in pain. The environment was busy and noisy, so Charles often struggled to sleep. During this time, his family, in particular his wife Mary, needed a great deal of support from the Admiral Nurse Service. The staff on the ward also needed support. I visited regularly and helped support and advise the staff to cope with these behaviours. Once the potential causes of delirium had been recognised and treated, we focused on managing their behaviours. We always focus on a non-pharmacological approach when coping with these behaviours. We encourage the staff to provide one-to-one supervision and ensure they meet the patient's physical needs by providing adequate diet and fluids, ensuring the pain is controlled, monitor for constipation and retention, and attempt to provide a quiet environment. Charles's family helped as much as they could. They brought in familiar objects from home, including a clock, which helped with orientation. They also visited throughout the day, and especially at meal times, ensuring Charles was eating and drinking sufficiently. Charles's symptoms of delirium did improve, but he was still demonstrating distressed behaviours at times. When a person is demonstrating challenging behaviour, it's often down to an unmet care need. It takes time and investigation to discover the triggers of these behaviours. Due to the length of Charles's hospitalisation, the staff got to know Charles really well. They were always determined to find out the trigger if his behaviour escalated. They had a list of possible causes they would work through. Their person-centred approach focused on comfort and safety, always ensuring Charles was treated with dignity and respect. His family always felt welcome, and they were reassured by the way staff treated Charles as an individual. For Charles, there were usually 1 of 4 reasons for his behaviours. He was either in pain, he was either hungry, thirsty, or needed the toilet. Pain was probably the most common reason for these behaviours. A small wound had appeared on Charles's lower leg, and over the next few weeks, this area deteriorated further. Also, the initial fracture had become unstable. It was now decided that further surgery would probably be needed. Amputation was even discussed at this stage, and again, the family needed a lot of support from our service. At this point, Charles was referred to an orthopaedic consultant in Merseyside for a face outpatient appointment. The planning of this appointment was lengthy. We were liaising with a different trust, which was a considerable distance away. The road from Barrow to the motorway is often described by locals as the longest cul-de-sac in the world. There's 1 main road in and out of the town, and the journey to this hospital could take up to 3 hours. Many issues were raised. What if Charles was unsettled on the journey? What if he needed the toilet? Would his family be able to travel with him and attend the appointment? Would he be settled when he got there? And then how long would he have to wait for the appointment? And then, of course, there was the journey home to consider. After several meetings and phone calls, the outpatient appointment was actually arranged over Teams. These reasonable adjustments were wonderful. The meeting went ahead from Charles's room. The consultant from Furness General was able to discuss all the options with the consultant from Liverpool. The ward manager was present. She was able to discuss the support Charles had been requiring on the ward. And Charles's daughter was present. She was able to provide her opinion from a family perspective. Charles was also present, but the atmosphere was so relaxed. Halfway through the appointment, Charles actually nodded off and slept for the rest of the call. I think we can all agree that this planning was all about person-centred care. Person-centred care is about tailoring care to a person's interests, abilities, and personality. It's about recognising a person as an individual and being aware that this person might need support from more than one professional. It's also recognised as an effective way of preventing and managing behaviour symptoms in dementia. It is acknowledged that person-centred care puts the person at the centre of healthcare. The patient is recognised as an individual where their needs and preferences are understood and respected. Person-centred care has been discussed since the 1980s. Harvey Picker recognised that while his wife was in hospital having treatment, although the care she received was advanced, it wasn't particularly sensitive to her individual needs or preferences. His observations suggested 8 key areas. Everybody should be able to access the right services at the right time, and this can involve adjusting appointments or treatment. Positive therapeutic relationships are at the heart of person-centred care, and the patient should receive appropriate, effective care to meet their needs. The care journey brings people into contact with a range of providers, and these transitions should be seamless. Providers should acknowledge the importance of a patient's family, and their involvement should be welcomed and supported. People should receive reliable, high-quality information at every stage of their journey, and the patient has the right to be involved in and make decisions about their care. Person-centred care demands a caring, holistic approach. Care providers should show empathy and respect and recognise an individual's emotional needs. And the person needs to be cared for in a safe, comfortable environment, and staff need to be mindful of a person's physical needs. The outcome of the outpatient appointment was that surgery was needed, and due to the complexity of the surgery, it would have to be performed in Liverpool. Again, the planning started. And although Charles was much more settled now, he was still requiring one-to-one support. Transport was discussed, and again, issues raised about the length of the journey. Charles's family were worried about visiting. They had open visiting on the ward, and would this be able to happen when they were in Liverpool? Where would they stay? Could they get time off work? Furthermore, Charles's bed wouldn't be able to be held for him while he was in Liverpool. This would result in a probable change of wards when he returned back to Barrow. And the staff on the ward knew him so well, and he was comfortable with them. After a great deal of discussion, meetings and phone calls, the surgeon in Liverpool made a decision. He actually decided to travel to Barrow and do the surgery here, therefore causing as little disruption to Charles's routine as possible. This demonstrates true person-centred care, where Charles's individual needs were put first. Never in over 25 years of working in orthopaedics have I seen these types of adjustments. The surgery still took a great deal of planning, and it involved a huge team effort involving many different specialities. Several weeks later, the surgery went ahead. Everything went to plan and the surgery went well, and Charles returned to the ward to be cared for by the nurses who knew him best. The surgery was a success. In the weeks that followed, Charles made slow progress at first. He was very quiet post-operatively, and he appeared uninterested in things around him. He wasn't really interested in eating or drinking. The family were again supported by the Admiral nurse team. I visited regularly and was at the end of the phone if they needed support. Gradually, Charles recovered. His appetite returned, and he started to look more like his old self. Eventually, he began mobilising again, and more importantly, he was pain-free. Several months later, Charles was fit for discharge, so the discharge planning began. It was agreed now that Charles would need 24-hour nursing care. This was a particularly stressful time for Charles's family. Mary in particular struggled, but was supported by the Admiral nurse team throughout the process. Just before Christmas last year, Charles was transferred to a nursing home in Barrow, close to his home. He has now settled into the environment well, and his family are happy with the care that he is receiving. And due to the location of the home, they are able to visit daily. Our Admiral nurse service is an acute service, but due to the length of hospitalisation and the relationships that were formed, I've continued to support this family following discharge. Charles was one of my first patients in this new role, and supporting him and his family has helped me gain and learn valuable skills needed for the vital role of Admiral nurse, as well as helping me develop and progress through the Admiral nurse competency framework. I believe supporting this family through their journey has helped me become a better nurse. It has helped me appreciate what families go through when their loved one is in hospital. In conclusion, I hope I've demonstrated the role of the Admiral nurse within our trust, described the causes of delirium, and shown the importance of identifying unmet care needs. Furthermore, and more importantly, I hope I've demonstrated the importance and benefits of person-centred care and how it should be at the centre of everything we do. Thank you for listening. Diane is now available to answer any questions.